and thank you so much for joining us. And my name is Professor Andrea Rockall from Imperial College in London. And tonight I'm going to talk to you about why is radiology AI like writing a book? So I don't know whether you've had any ideas or thoughts about how I might proceed, but I just thought it would be a little bit fun to have a slightly light-hearted theme amidst all the difficulties that we're all facing in these difficult times. So if only I can advance. Hold on. Oh, okay. So sorry about that. I'm not sure. It's just from the screen sharing. I'm having a little bit difficulty advancing, but I'll get used to it. So the first step in writing a successful book is probably having a great concept. And in addition, we want to have a really good title. Now, it's possible that different types of categories are quite acceptable for books. So you might be thinking about a great easy read, something for the beach, and a more of a basic, you don't have to concentrate too hard in this respect. Other books are in a different category. They're big, thick classics like War and Peace, where you might have to really concentrate quite hard, work your way through, but in the end, it's a fantastic read. And finally, we do see some literature which is much more innovative, perhaps sometimes difficult to understand even, but that ends up being truly outstanding, for example, winning the Booker Prize or the Nobel Prize for Literature. And all of these things have value as books, but they are in slightly different categories. And we can think a little bit about machine learning in a similar way. The main thing is that we've got to have, right at the outset, a great idea to solve an important problem. I think without having that, a lot of the work that we have to do to successfully develop a machine learning a radiology study is wasted if we don't have a problem to solve. I guess the exception to that would be if you're just trying to work on a particular methodology or what have you, but we really ultimately want to be able to solve a clinical problem. And we can also have some different categories of studies similar to the books. So we might have the so-called beach read. Here we have an important study, but we have very straightforward images. And I've just taken an example here from arXiv, where one group have been looking at trying to identify Colles fractures. So we don't have multiparametric imaging. We don't have the difficulties inherent in different slice thicknesses and different signal intensities on MRI. It's relatively straightforward. We might be deciding to look at a relatively classic problem. So I've given an example here on the top of a segmentation in a brain tumor. And I've just taken this image from Kamnitsas et al., who developed the Deep Medic here at Imperial College. We might be considering looking at detection of tumor on mammography and in screening, which is a really, really important problem in radiology, one which will make a huge difference. But it doesn't stop multiple groups working in this area because it's a classic problem and it's an important one. And a similar story could be told for pulmonary nodules, where again, it's a classic problem, but it's a really important one as pulmonary nodules are so common and we often miss them. So detection is important, but we also sometimes don't know what they are. So characterization is important. And having multiple groups working in this area adds to the field. And finally, we might be going for something that's really a little bit more difficult, where we're not sure if we're actually going to make it. It's possible that the results will not be what they want, but we may push the boundaries and discover new things. So I'm going to talk a little bit today about two of my studies, an NIHR-funded Malabo study, the machine learning in body oncology and machine learning in myeloma response, where really at the outset we have a good idea, but we're not really sure if we're going to be able to fulfill our objective. And I'd also like to touch on one study also from our imaging lab, from Mariana Inglesi and Erica Abouagier, who are looking at detection of Alzheimer's disease. So we've identified a great idea to solve an important problem. And whether this is a beach read or whether you're trying for something more innovative, or maybe even not me, but maybe one of you is trying to go for the Nobel Prize, um, whatever type of study it is, we need to carefully consider the unmet clinical need, because it doesn't matter whether it's a relatively simple or very complex study, both of them would need to solve an unmet clinical need. Another thing to consider when we're trying to decide on our big title and what our study topic is going to be is, are there big players interested in this area? For example, one of the reasons we went for the whole body MRI study was that the NIHR commissioned a study on whole body MRI in lung and colon cancer. They were interested in this. And ultimately that study led to the machine learning component of the study. And also, NICE identified whole body MRI as the imaging method of choice for myeloma. So we thought that there were some big players interested in this area, so that might lend itself to funding. You also need to look at whether there's current work in the area. What are other people doing? Is it saturated, or is this a new area that you could develop? But even if there is active research going on in that area, you may consider that you could contribute nonetheless to the field. You may have student projects to train, and this is a very important role. So for example, if you still wanted to work on lung nodules or breast lesions, there's no reason why not, because this is an important area. And there may be lots of student projects that can teach people techniques. It may be, as radiologists, that we want to develop a further validation data sets for outside collaborators or internal validation. And this is an extremely important aspect of getting our studies and machine learning algorithms out into clinical practice. And of course, you might wanting to try new machine learning methods to solve problems that other people have tried in their own way. But we do need to convince the funders. We need to show them that there is a need for this AI solution that you're proposing. We need to show some readiness to be able to do the study. And also we need to consider what mitigations we might have in place in case things go wrong. I also think at the beginning, we need to pretty well ask what the patients think. So this might be a little bit like the publishers doing a marketing with the patient group. And in one study, we sent out the idea around to our patient group, and we try to get ideas like this to come back to the funders. You know, the patient would say, I think this is a brilliant idea. It could become standard practice. It would improve patient outcomes. The concept and execution seem good. I think it's an excellent study. And these type of things, patient feedback from a small survey or what have you, can be very helpful for funders to see the interest. And we can also ask, what do the end user clinicians think about it? Could it be something that could help assess risk for patients, or could it provide an early warning? So these are quite good things at the beginning to get started with. Now, it may be that you've sold the title to the publisher, maybe the funder, but they might want you to tell more of the story, preface the problem in a bit more detail. Let's see, this is the whole body MRI. Where would we go with the funder here? So the premise was that the Streamline study was being funded. This was for patients being staged with colon cancer. There was also lung cancer. The problem we have is that patients come along and have a CT of the chest, abdomen, and pelvis. Maybe we identify a lung nodule. Could it be a metastasis? So the patient then has an FDG PET. And then there's something funny in the liver on the PET. So then they say, oh, well, we better have a liver MRI. And so then the patient then starts getting a headache because they've had so many investigations. And then they have a brain MRI. And so the question in the Streamline study was whether whole body MRI with DCE liver and post-gadolinium brain could allow a single investigation to stage and plan the patient's treatment. So could one test replace all of these tests? And those two papers were published, both for the lung and for the colon. And the interpretation was that whole body MRI staging pathways had similar accuracies to standard pathways. They reduced the number of tests per patient, reduce the time to get to the final stage, and reduce the cost of staging. So this looked like a very good premise to go forward with a potential machine learning study to help readers read whole body MRI. And what about whole body MRI myeloma? Well, we can see this chest X-ray where it's very difficult to see disease. On MRI, We can see extensive disease using the diffusion weighted imaging. But we can see that the whole body MRI is a little bit difficult to interpret in this another patient where, unless you're an expert, you may have some challenges. But NICE came out with the guidance in 2016 that this was the best way to image myeloma. And there has been a big publication of the MyRAD score by Christina Messiou. But the problem is we have evidence that whole body MRI is advantageous in myeloma and now in colon and lung cancer, but the technique has not really translated into clinical practice. So why is this? Well, we can look at healthy volunteers' whole body MRI, and we can see that the bone marrow is quite variable depending on the age of the patient. And if we compare this to myeloma patients, unless you're an expert, it may be quite difficult, for example, to understand if this patient has diffuse myeloma compared to one of these younger patients on whole body MRI in the healthy volunteer group. And so it's difficult to interpret. And in addition, whole body MRI is complex. There's a lot of scans, and increasing complexity has perhaps reduced clinical translation. So the question was whether machine learning could help radiologists read whole body MRI, and this is what we went to the funders with. But the funder might say, well, this sounds like a great idea, but can you actually do it? I'd like to see, perhaps like in the publisher might say, I'd like to see a sample chapter before we give you some upfront funding, and the funder might want to see that we have things in place that we could actually achieve the objective of the study. So we need to set the scene and describe the characters, and depending on what type of book or study we're doing, let's consider some different examples. So if we were looking at a book about Henry VIII, it might be a relatively narrow field. We might have a story about just the children of Henry VIII. On the other hand, Hilary Mantel did 3 very large books all about Cromwell and Henry VIII, very complex, needed a lot more data to get that type of book out. So we might have a small need for data. Maybe we just need the images and maybe a confirmation of a fracture by a clinical radiologist, whereas we might, on another study, need very complex data, including genomics, outcome measures for the patients, what treatments they had, etc. So setting the scene and describing the characters could be a little bit like collecting the image data, the clinical metadata, and preliminary output. So this is really setting the scene and annotating everything. What data would we really like to collect to answer our objectives? Are we planning a relatively straightforward analysis, such as identification of a fracture or a pneumothorax? Or are we trying to identify a predictive or prognostic biomarker? What outcome measures do we need to collect? What clinical metadata would be needed for multivariate analysis rather than just univariate analysis on the imaging? And then we have to ask ourselves, is the data actually available? Because we need to be sure before we go ahead with a big study. And that can take some time. How will we handle missing data? Even with prospective studies, we get missing data because patients fall out. And is the study actually going to be feasible? So if we take back to the publishing metaphor, we might want to write a book about the princes in the tower, but nobody really knows what happened to them. So a lot of the stories are all mythological because we don't know. So we have to be sure that we have the data so we can actually write the story rather than trying to make things up along the way. Data curation is at the absolute heart of machine learning studies. And we need accurate data collection and annotation, mainly to avoid false discovery. We don't want to put a lot of time and effort and potentially taxpayer money into large funded studies where we end up with false discovery. We really want to avoid this at all costs. So I'm just going to look at some of the real life challenges related to MRI data sets in the whole body studies that we've been working on. And we have lots of problems with scan heterogeneity, different acquisition parameters in different centers, even though, for example, the Malibu study, all the cases from the Streamline study were prospectively collected according to protocol, but each of the different 15 centers have different scanners, slightly different parameters, and inevitably there will have been differences in slice thicknesses due to the size of the patient, differences in signal intensity, vendor, and therefore we get heterogeneity related to the protocol and the patient. So here are some examples from the Malibu study, which are all segmented according to their healthy organs. These were all collected on the same scanner at Imperial for our healthy volunteer aspect of the study. And we can see that we have a good chance of developing some segmentation algorithms for the different parts of the body. But once we start moving to the real life patient data with 15 different centers, we can see that we start developing lots of difficulties with the data. We can see that some of the patients don't have their head included, and although that's okay for us radiologists, it's difficult for machine learning. We have differences in signal intensity, and we have various linear artifacts between the stations and what have you. So this becomes much more difficult. And data harmonization, intensity normalization becomes very, very important. And of course, the performance of the algorithm that we developed in healthy volunteers inevitably drops once we have these changes in the input data. So the data cleaning becomes a really, really important part of this, this next step. It's essential for good model training. Obviously, in some studies, it's straightforward. If you have plain films like a chest radiograph, it's a little bit easier in CT, but nonetheless, we still have challenges. And MRI with multiple different sequence types becomes the most difficult. Well, maybe other people have something else that's more difficult, but this has been my most difficult challenge. We cannot underestimate how unclean the image data can be, particularly with MRI, where we can get data that is corrupt. We have missing slices between stations, multiple artifacts from metal or breathing or ghosting, and of course, some differences in protocol that happen in real life practice, which we can't avoid because patients are different shapes, sizes, sometimes they can't hold their breath, etc. So I just want to go to an outside study that's been published in Radiology, looking at a very nice study in prostate MRI, where they use deep learning versus clinical PIRADS assessment. And I just wanted to show you how some studies cope with this data heterogeneity. And I want to say right at the outset that I don't mean to criticize in any way. I just want to illustrate some of the issues that we're up against. So in this study, they used a training set of 250 MRI scans, and they had 28% that had significant prostate cancers confirmed at biopsy. And they had a holdout test set of 62 MRI scans, 37% of which had a significant prostate cancer at biopsy. So we had a reasonable class balance between the two. And they produced these beautiful images in their study where they have segmentations with ground truth, a UNET tumor segmentation, ground truth prostate volume, and then the UNET volume, as well as some probability maps for the prostate and for the significant tumor. So we can see these really lovely, lovely segmentations and probability maps. And we can see here that the training set using cross-validation has this particular ROC curve. And when we come to the test set, we have some reduction in the validation set, but it's not too bad when we compare with the training set. And this is an inevitable drop in the test set on the whole, but it's not too bad. So let's just look at the data used to develop this nice study. So if we look, they started with 786 scans of consecutive patients that were identified with PSA levels or suspicious digital rectal examination, that were undergoing biopsy or urgent repeat biopsy. And then 371 patients were excluded because they weren't done at the German Cancer Research Center, so they weren't the same center. Then they excluded patients, they wanted patients that all had the ESUR particular guideline for the MRI scanner. So then they had to exclude some patients for that. 69 patients were excluded because they were, the MP MRI was done on a different scanner within the German center. So they needed same center, same protocol. They then used the same scanner. And then they had patients who had hormones, artifacts, prior radiation therapy, prior focal therapy. And so in the end, they had this 312 patient data set, which was quite homogeneous. So we can see that they went from 700 or so patients down to 312. And so we've lost all these patients that had difficult cases in order to try and get a nice output. Or to, at the beginning, we need to see whether something's going to work, there's no doubt. And then we maybe see if it works in a wider group of patients. We also have challenges in determining ground truth. So we have this labeling noise. How good is our ground truth? So when we label a lesion, if it's not been biopsied, how do we know if it's cancer or not? Especially, for example, in diffuse disease in myeloma, where does the normal bone marrow start and the diffuse disease start? It's difficult. What is the margin of the disease? And what should we do with artifacts? Should we include them? Should we not include them? We have to make a decision how to handle those. Who is right between different readers? Do we take a mean? Are we labeling for detection or are we labeling for radiomics? So detection, we maybe want just to be able to spot the lesion, but radiomics, we don't want to muddy the waters with other normal tissues around the tumor. So we have to consider whether we're going to use a boundary box versus a high confidence segmentation for tumor only. And also, for example, can we label globally? Sorry, go back. Can we label globally? Did the patient develop a cancer, or did the patient survive for a shorter or longer period? And sometimes we have to be limited with relatively weak labels, such as we haven't got a biopsy, but we have an expert reference panel to say if something is disease or not. So we have a range of ground truth strength in all of our studies. We also have to think about some of the challenges allocating cases to training and testing. How can we do this without bias? What do we do about class imbalance? What if the relevant finding is only present in some or few of the cases? What we did in Malibu, because we had this problem with lots of different vendors and different cases from different centers, we did a stratified allocation. The statistician did this without reference to any of the investigators. We stratified according to the site of MR acquisition. We made sure that training and testing had similar proportions of lung cancer and colon cancer, as well as similar proportions of presence or absence of metastatic lesions. Ideally, this allocation should be done by a study statistician, and we also had an independent statistician that placed the original seed as the starting point for the allocation so that there couldn't be any bias in that respect. Sometimes it's very difficult to do this because we don't have the whole data set in at the beginning of the study. So in Malibu, we had all the data in pretty well and we could categorize the data. But even then, once it was allocated, we lost cases on one side or the other because of some technical issues. In the Malamar study, we realized that having collected all our data, we had various problems that required us to collect more data. So although we'd already allocated to training and test in one center, we then had to mix it up again. So things are not always perfect, it's real life. We do lose cases along the way due to problems with data curation. And so sometimes what we want ideally for our allocation goes a little bit awry. And in the end, we need to then clearly say what we did with the data. And for Malibu, you can see our consort diagram, where we started off with our streamlined cases, 299 colon cases, 187 lung, so many with METs. We then lost some because they weren't available to us on the image repository. We then knew what we had for Malibu. We then divided, according to the statistician, into clinical validation and training. We then lost some because of technical failures. We then had our final data set, which we had a sort of internal holdout. And then once we had our final machine learning output, we came across to our clinical validation set. We lost 5 of those because of technical problems. And then we had our final clinical validation. So I think it's important for us to try and follow these consort diagrams just as per starred criteria. Right, well, we've allocated into training and testing. And then the third part, this is where the plot thickens. So if we look at the analogy with publication, in War and Peace, I've got to say that I lost the plot a little bit when it came to the war scenes, same as with Lord of the Rings. For me, this gets a little bit woolly. And I would say that my machine learning colleagues are brilliant at what they do, and I try and follow, but sometimes it's pretty tough for a radiologist like me. but I'm just going to go through some of the machine learning developments we've been looking at in myeloma disease classification. And this is work developed by Ben Glocker and our postdoc Talha Kaiser, looking at something that they're developing called multiple instance learning. And here the problem is that we have quite a large scan and we might have very small areas of disease. So it's quite difficult training because we have a very small focus within a large volume. So we need to try and help with various methodological developments. Firstly, we want to be able to classify each patient as whether the patient has disease or not. So we want an overarching whole body disease prediction. And then we also want to try and identify separate anatomical regions where the disease sits. And ideally, the plan is to develop a single machine learning model to achieve these objectives. And the first thing we did was to automate the bone segmentation for different bony regions. We used the Deep Medic sequence developed in the Biomedia group in 2016. And following this, each of these different regions then became instances that were separately cropped out and put into a bag. And in each of these instances, each of one of these might have a site of disease or might not. So you might have a negative instance and you might have a positive instance. And Christina Messier and myself and Tara Barwick have been labeling all of these regions. And we can have a bag of 3D instances, which is a group of cropped regions that are individually labeled. And overall, the bag could be classified as positive or negative based on if there was at least one positive instance within the bag. And so we can look at patients with diffuse or focal disease. Each of these different instances will be labeled. And then we also have a set of healthy patients or patients with inactive myeloma, which are all labeled as negative. And then we can start training the pipeline. Step one, we have to segment out the skeletons. We then develop the bags of separate instances and then go through the machine learning pipeline, first for a binary disease classification as to whether the patient has diffuse or focal active disease, or whether they're healthy and inactive negative cases. And then we add in the multiple instance learning in order to refine the process to the anatomical space. Talha and Ben also developed some synthetic data in order to test and train the model in this area. And then to carry on using the bone labels, which us radiologists have tried to provide for our machine learning colleagues. And then each of the training data can go through this step one segmentation, step two instance annotation, and then step three, the CNN with the multiple instance learning in order to label all of the bones and identify the positive and negative steps. So we're getting there. We have ongoing experiments, lots of challenges, including data normalization and model generalization, but it's an exciting project. I hope we'll make it, but we still have lots to go, and it will go into clinical validation later on in this year. I'd also like to highlight another really challenging study, again, where it's one of those studies where when you start, you may not know whether you're going to make it or not. And this was a lovely study developed by Mariana Inglesi in our imaging lab and Eric Abawagier. And the premise here was that they were trying to identify whether or not they could identify patients with either healthy brains, moderate cognitive difficulties, or Alzheimer's disease on MRI. And here, the input data was a T1 weighted MRI scan. Brain segmentation was a very complex process. And then radiomic analysis was undertaken using a radiomic platform in our lab. And these were related to the patient's clinical outcomes, whether they were healthy, have moderate cognitive impairment, or Alzheimer's. And using this disease identification process, and a TextLab software-based program, we could see that actually the brains could be classified very, very well into their different categories, and it performed better than the ground truth standard, which was a radiologist looking at the hippocampal segmentation. So this looked very promising. Sorry, I've advanced slightly too quickly. And then in addition, evaluation of the method looking at textural features in the subcortical regions was also developed, and Mariana identified that there were clear differences between patients with moderate cognitive impairment versus those with Alzheimer's disease. So this exciting development was very, very difficult to perform. And what would be the potential role here? To be able to quantify changes and to differentiate between an early cognitive impairment compared to Alzheimer's disease could then be used to measure signs of either stabilization of disease or deterioration within, say, a clinical trial of a treatment for Alzheimer's disease. So this would lead to some kind of quantifiable biomarker that could be used in a clinical trial environment. Okay, so we're getting on to the dramatic finish now. The end of the book, we want to get to an exciting nail-biting end, and it's the same thing with some of our machine learning projects. For sure, I know that when we got to the end of the Malibu project, Ben Glocker was wondering how it would turn out, because of course all the data is separate from him. He has no idea how the performance will be once it goes into the radiology department and we get things onto the PACS. So what we did in the Malibu, we had phase 1, which was the healthy volunteers. We did a statistical validation in the lab for all the segmentations. We then trained detection of lesions, which was a little bit like an instance learning, where we segmented the anatomical sites first, the bones, the liver, the typical sites for metastases, the lungs, and then we did lesion detection. And then we went on to the clinical validation with the radiology reads. Of course, this was a retrospective data. It was not a prospective validation, but it was a holdout data set from the Streamline study. And we had to plan the study. So how did we try to plan our clinical validation for our nail-biting finish? Well, we first of all got all of this complex data stitched together into a state where we could scroll through volumes of disease, and we loaded them onto a cloud-based PACS system. And here I've just taken a screenshot where we have the T2, the diffusion, the ADC map, and here we have the overlay of the machine learning output on top of the tumor. And we can see here that this patient had a cecal tumor, and this was a high probability for cecal tumor finding here. And the readers could scroll up and down with the overlay. They had the option of looking at any of the different sequences that they wished, and recorded whether they thought where the primary tumor was and whether or not there were metastases. And we had to decide how best to do this, again, to read without bias. So again, we relied on our statistician. We had a number of readers, and you can see here reader 1 in the Excel spreadsheet, and reader 2 and reader 3. They were allocated cases by the statistician. Some of the cases the readers would not know, but were actually inter-rater reads to compare between different readers. Some of them were the primary reads. They were the primary reader rather than the secondary reader. And they had 2 different visits. So we had, so here we had reader 1 had a mixture of reads. Some of them you can see were colon cases. Some of them were lung cases, STC and STL. And then some of them had machine learning and some of them didn't have machine learning, depending on which visit they were reading. Yes, and all of them had, we had a number of inter-rater reads. This was our first reading day. We had a scribe who recorded the CRFs, and Katia De Pepe was our first reader in the study. And we looked at the diagnostic test accuracy of the comparator study, which was no machine learning, versus the index study, which is with machine learning. We randomized reads statistically so that there couldn't be a sort of training bias. We collected reading time, inter-rater and intra-rater agreement, and we also looked at expert versus non-expert reader. And that is submitted for publication now, so the results will be coming out shortly. But I also wanted to raise this very nice paper from radiology, which looks at methodologies and guides for evaluating clinical performance of artificial intelligence. And here really this is a much more realistic setting. Although in Malibu, we read the studies in the reading room, all of the readers knew that those scans were not going to affect patient care. Whereas here they've really, this is really the next step, where we have eligible patients that are randomized to patient care with artificial intelligence or without. Or, for example, you could say, okay, for 2 months, we're going to have all the scans with artificial intelligence, 2 months without, and then with and without, again, trying to avoid training bias. And then you can compare the two groups. And this is a very good article if you want to start planning any clinical validation type studies. I just want to mention that there are also two approaches. We could look at pure machine learning, like completely running on its own, did it detect disease, versus a radiologist with the machine learning output. Both of these are valid, but in the end, we do need to identify what happens when these tools go out into clinical practice. Of course, we also need to get the tools translated into a workflow. Here, I've just, we're trying to translate one of our tools into an NHS workflow. So we've got our data ready. And then we have the whole anonymization pathway that's been approved by information governance. And actually, we're using a research PACS, which will be identical to our live PACS. We then have to develop a system to push the data onto the GPU, and then run the program and then push it back onto the PACS. And we have to think about how we want that to look. So we have a plan for the pipeline software, we have an AI algorithm. So we need to now incorporate this into a sort of research environment that's much more similar to PACS in order to get this into clinical care. And at this point, we need the production team, the publisher, the marketing to really sell the book. Hopefully, we're going to end up with a blockbuster. And that's what we all hope for, really not just for the glory and scientific excitement, but what we're really after is to solve problems, to look after our patients better, and also to develop patient care that is affordable, democratize more complex care, and to help areas in the world where they're short of radiologists, where some simple tools might help them deliver healthcare for simple things like just reading thousands of chest x-rays in Africa, looking for TB, which is one of the biggest killers. So in conclusion, my premise was that radiology AI is a bit like writing a book. We've got to start with a great title, which would be identifying a fantastic unmet clinical need. We have to set the scene, sorry for my typo there, and we have to develop the characters. In our case, what data do we need to fulfill our objectives? We need to have the data, so we need to imagine our characters, and we need to do a lot of data annotation, data cleaning and annotation, which is the same as developing the characters. We then need to develop the plot with the model training, identify problems with model training and innovate. Whoops, oh dear. And then we have a dramatic finish. Will it work when rolled out in a clinical setting? And can we get that technology transferred? So I don't know if you agree with me, but that was my premise, and I guess we can discuss that now. And thank you very much for listening. I'm going to unshare my screen now, right? I'm going to stop. Is that right?
Oh, you can leave it if you want.
I can leave it. Okay, that's fine. Perfect.
Thanks so much, Andrea. We've actually got a couple of questions from the audience.
Okay.
The first one says that, do you involve many different people and experts when writing your book? What other expertise do you usually need for writing a good book? So we're radiologists, primarily clinical radiologists, and we want to, we've got a great idea for where AI can help, but what team do we need to surround ourselves with to really?
So I took out a slide. I actually had a slide on the team, but I thought it was going to get too long. So the team is absolutely critical, and you can see all the different steps that we have here. I think right at the beginning, you want to have the team together. You want to develop the title and the whole concept with the machine learning scientist, really ideally with the software engineer. Is it going to be feasible? The radiographers, the whole information governance team. So who do we start with? So if we think of, let's think of the Myeloma study, because that's the one that's most fresh in my mind at the moment. There we had I'm not a myeloma expert, but I was working with Christina Messiu, who is a world-renowned expert in myeloma. I was working at the Marsden, where they have a huge data set of myeloma scans. And just as I started, that NICE guidance came out. So we thought this was a great idea. Who do we need to gather together to help us? So we had Ben Glocker, thankfully, agreed to help us as the machine learning scientist. He was already working on the whole body MRI with Malibu, so he had some ideas and concepts in the background. So we had Christina, who's the clinical expert. There's Ben Glocker, who is a whole body MRI machine learning expert. We then joined up with Martin Kaiser, who is the he is the clinician looking after the patients, who knows a lot about the clinical data about how to evaluate whether patients have active disease or not active disease. We then have Simon Doran, who is an expert on imaging informatics, developing the whole XNAT repository, how to store the data, really complex management of the data in the repository. And then we have statisticians who are diagnostic test accuracy and methodology statisticians involved. We had Theo Barfoot, who is our fantastic MR physicist, who helped curate and clean all the data. And that was literally a 2-year job. It was huge. But now, hopefully, we have this fantastic data set that can be used for future studies as well as our current study. And I'm trying to think. Oh, yes. And of course, we have all the technology transfer team from the ICR, Institute of Cancer Research, and the Royal Marsden for all of the identifying any IP as it develops. I'm probably forgetting somebody, but the team is huge. Yeah.
Great. Thanks a lot. And then, we always come back to this point. Data is the lifeblood of any algorithm. Yeah. Data annotation, cleaning, and labeling is one of the hardest and most laborious parts of algorithm development. Are you looking at active ways to automate some of these processes, or is it still very much manual segmentation with consultant radiologists overseeing every single segmentation and label?
Okay, so what we did so it depends on the type of study. So what we did for Myeloma, just to continue with Myeloma, here the segmentate. We decided at the outset, we had to think long and hard, would we start segmenting all of the tiny myeloma lesions, which might be just one big lesion in a patient, which would be relatively straightforward, or it might have been thousands of tiny lesions, or it might have been diffuse disease. So we had to think, how on earth are we going to manage this? So what we decided to do was actually to do boundary box of regions. So for example, we did the skull as one region. We did the upper spine. We didn't even call it cervical because it's all boundary box. Then we did middle spine, lower spine, long bones, sternum. And because we're not doing specific radiomic characterization of disease, we wanted to identify boundary boxes. So we actually, Theo segmented about 70 or 75 cases. I checked all of those and they were pretty well segmented, but they were boundary box, not perfect. And then we used those 75 cases with the Deep Medic to train a machine learning algorithm to segment out the rest of the 800 strong database. So, and then Christina, myself, and Tara have labeled each of those regions as to whether a region was healthy bone marrow, diffuse disease, treated disease, or focal deposits. So we may go on later to do more focal segmentations, but at the moment we trained the skeletal segmentation on about 75. Other segmentation tasks are different. For example, if you're doing radiomics, I think it's important, but I might be wrong, I think it's reasonably important to make sure that you're just segmenting the disease and that you're not doing a boundary box where you could alter the character of the radiomic approach. So then I usually say to the people that are segmenting, all the trainees that are helping, just say, look, if you're not sure, for example, in ovarian cancer that I work in, which you can just sort of merge with bowel, I usually say, if you're not sure that you've got partial volume artifact, or if you're not sure if it's bowel or tumor, err on the side of caution and just take the tumor, because we're looking at a radiomic approach rather than a detection approach. So I can see Daniel is nodding, so I'm hoping that that's what most people would agree with. So I do think we want to speed up segmentations with as many support as we can from the machine learning world, where they've obviously got lots of segmentation algorithms out there. But sometimes you do need to really check on the ground truth carefully before you go ahead. Yeah.
I know with stuff that I've done in the brain, segmenting lesions, there's a lot of commercially available algorithms out there to do automated segmentation, but they generally don't work as well as if I've done it as a ground truth myself. And then you need to really have trust in your, your testing data set.
Yeah, and also, like, sometimes we find that if we use a sort of semi-automated tool to help us, sometimes the corrections take longer than it might have taken to actually originally segment the lesion. I think with a boundary box and something like bones or something with a lot of contrast, whatever, probably a semi-automated technique is not a bad way. But yeah, very often I'm glad to hear that other people also have similar problems, because sometimes you just want to do it yourself.
Well, the flip side of that is also, we don't know what the baseline heterogeneity of, we consider what we do as the ground truth, but we haven't looked at our own heterogeneity within our own segmentations.
Yeah, I mean, that's what I was saying about data labeling. The labeling can vary depending on, well, it does vary depending on the annotator. And, doing multiple annotator studies is really, really important to understand a sort of annotation test retest approach, because and actually in one study we did in an ovarian cancer radiomic study, just to see how robust the radiomic prognostic vector was, we had our machine learning scientist Fadi Kanavati. He did some reduction, sort of automated reduction and expansion of the segmentations, just to see how robust it would be, just to automate other readers, just that's a way to automate that process. Yeah.
Yeah, just a question, like, out of personal interest, maybe, because obviously the team you were talking about is really big, and I think that's actually a good thing, because obviously there's some things that we as radiologists do not cover, like machine learning and stuff. And you were talking about getting funding for that research. Just was wondering, is that kind of industry partnerships, or is this all kind of research grants and everything, or where do you actually get funds, kind of?
Yeah, so I mean, I do, as Shah will know, we work together in the same imaging lab. We have a range of projects, some of which just are like registrar projects where we're doing something relatively simple that we're kind of doing as unfunded projects, which will probably be less resource intensive. But for example, the bigger studies like Malibo or Malimar, those were funded by the National Institute of Health Research, so the NIHR. And those larger studies, I don't think you can feasibly do without funding, because you need to employ people to, I mean, it took Theo 2 solid years to curate that data set, and he worked full time on the project. And that was very, very meaningful to the ML side, because then they have a data set where, they can really work on a data set which is clean, where problems have been identified, etc. And, you can't just ask somebody to work for free for 2 years to curate the data set.
Right.
In my own work, I typically work with, well, the NIHR is my major funder. So I have 3 NIHR funded studies, and I have 1 CRUK funded study. But I think more and more now to be working jointly with a commercial team is really important, because you can then integrate the technology transfer as you go through the project. It's not always possible to find an industry partner, but many of the big funders like NIHR Wellcome or the Horizon projects are looking for joint projects between academics and industry, and that makes sense for the whole pipeline for the technology transfer into the commercial product. But yeah, I'm a bit of an academic beast, and I probably need to develop my skills to join some academic partnerships. But I think, like I said, you've got the beach read all the way up to the kind of big innovative, it might not work project. And some of the beach reads you might want to do. So for example, we have some of our intercalated BSc medical students doing some projects where they're just literally doing segmentation studies on previous data sets that we've collected to look at inter-rater agreement and, you know, various things. They learn how to do their dice coefficients and they learn all the methodologies. And that is part of training the research scientists of the future. So it's important, but it's unfunded. Yeah. Yeah, right.
I think that answers all the questions that we've had from the audience. At this point, I'd like to thank Bracco Imaging for sponsoring the USOMI webinars, and it's just such a pleasure to have Professor Andrea Rockall to kickstart the year, and wishing all our viewers a very happy new year. We can't guarantee blockbuster algorithms. I think in Andrea, you can always guarantee a blockbuster speaker. She's one of the hardest working people I know. She's completely devoted to training and mentoring. You probably would have seen that she's announced her candidacy for the second vice president for ESR, and on behalf of everyone at USOMI, we wish you all the best with the upcoming election. Thank you very much, Andrea.
Thank you, Shah. Thank you so much for inviting me to give this webinar. I really enjoyed.
Thank you so much.
Okay, bye-bye now.
Bye.